Close?
Yes. Yeah.
Okay, good. So I have stopped my sharing.
All right. Good morning to you all. My name is Dr. Tongai Chitsamatanga. I'm an orthopedic surgeon in Zimbabwe with special interests in pediatrics. So today, I'd like to just acknowledge the local faculty. We've also invited our pediatric colleagues, obstetric and gynae colleagues, and other orthopedic colleagues from around the region. And also want to acknowledge our trainees and also commend our Secretary General of the Zimbabwe Orthopedic Association, Mr. Kim Mageza, who has really made this meeting possible. I also want to introduce our guest co-presenter, Mr. Alaric Rugis. So he was the medical director of Miracle Fit India and Global Operations, and is the current vice president of the Pediatric Orthopedic Association of India. He has also been author and co-author of over 100 publications. He's going to be the one presenting on the treatment of club foot. I would like to introduce our main chair, Dr. Pamela Samoyo, who will then take it from here. Thank you.
Good morning, everyone. Thank you, Dr. Chitsamatanga. And since I think we are right on time, we'll ask Dr. Matsenga to start his presentation, and then we'll take it as we go. Thank you. Dr. Matsenga, is he here?
Screen sharing. Yes, I'm there. I'm there waiting for this, for the screen sharing.
Okay.
Okay. Mr. Mageza. Hello, good morning, everyone. My name is Kudakwashe Matsenga, fourth year trainee in orthopedics, on the topic of club foot. So the learning outcomes for this presentation, after the end of the presentation, I would like everyone to be able to define what is club foot, to know a bit of epidemiology of club foot even in our own setting, to understand a bit of the etiology and pathophysiology of the condition, and how to make the diagnosis, how to classify, to treat, and also to appreciate some of the complications that come with treatment of the condition. Okay. So in terms of definition, club foot is also known as congenital talipes equinovarus, which in simple layman's term that is present at birth, and it is recognized by a foot that is pointed down, rotated inwards or turned inwards. So the acronym CARE is used to describe the deformity, and it is also used in managing the deformity. So essentially, the hind foot is in equinus, that is pointed downwards, and it is also in varus, and the midfoot is in adduction, it covers, as well as the forefoot that is adducted. So that picture there is just to show some of the variants or variations of club foot or differential diagnosis of club foot. By far, the most commonest is the talipes equinovarus that we are going to discuss today. But that is just to illustrate that there can be other types or forms of club foot. So in terms of epidemiology, it is a fairly common condition with an incidence overall globally of between 1 and 2 per 1,000 live births. The incidence is highest in Hawaiians and Maoris, where it can reach up as far as 6.9 per 1,000 live births. But it is important to note that 80% of children born with congenital equinus, Talipes equinovarus, are okay in low to middle-income countries. The lowest incidence, however, is found in the Chinese and in the Zimbabwean incidence, according to Madhiri et al., who conducted a retrospective study at a major referral center, was found to be 0.9 in 1,000. Then in terms of male to female ratio, males are affected twice as much as females. This does not mean that it is a sex-linked disorder, but it is due to what is known as the Carter effect, where the female require more of the genes for them to express the condition, but it's not really sex-linked. And it is also important to note in half of the cases, the clubfoot is bilateral. For the types of clubfoot, they are essentially divided into typical and atypical clubfoot. So the typical clubfoot is the one that is found in otherwise normal infants, and it generally is easier to correct, and this can happen with 5 casts or in and around 5 casts, and the long-term outcome with concerted management is good to excellent. And for typical clubfoot, it can be divided into positional clubfoot, which is present at birth, and it is not really a true clubfoot. It is thought to be a result of intrauterine crowding, and it usually corrects with 1 or 2 casts. Then if the typical clubfoot is delayed in terms of being treated, that is beyond 6 months of age, then it is termed delayed treated clubfoot. Then recurrent typical clubfoot occurs when the typical clubfoot is treated, but then there are relapses. The relapses can be due to incorrect or improper technique in the concerted management, or incorrect bracing, as we shall discuss later. Then alternatively treated clubfoot, other methods could have been used that are apart from the Ponseti, maybe surgical or other methods like the French or the kite. And for a typical clubfoot, this one is usually associated with other problems, and correction of this type of clubfoot is usually more difficult. The subtypes of the atypical clubfoot include the untreated or neglected typical clubfoot. So if a patient presents 2 years without with their clubfoot having not been treated, it's usually classified as untreated or neglected. Then a rigid or resistant clubfoot, we shall discuss again. These are their slides to discuss some of these ones, so we can move on to the next one. So that one is a rigid or resistant clubfoot. It is typically presents with a crease on the deep posterior portion, and also a transverse crease on the sole of the fist, or also of the feet. So, and then the fifth metatarsal or the fifth toe is hyperextended and short is shown, and sometimes it presents in thin patients or in fat patients, but the outcome or the prognosis is usually poor when it is in the chubby babies. It is usually difficult to correct. Then neglected clubfoot, as I mentioned, if a patient presents at the age of 2 years or more with untreated clubfoot, this is typically how it presents, and it is usually because people could have failed to diagnose the clubfoot early, or they could have presented late at the hospital. So it's two ways: either because of the patients failing to present for appropriate treatment, or they would have presented, but then the practitioners, for lack of knowledge, would have failed to treat the clubfoot. So as you can see, it is quite disfiguring, and the aim of this presentation is to help us be able to make a diagnosis and to prevent people presenting with neglected clubfoot. Then for syndromic clubfoot, the picture on the left is showing a baby with clubfoot associated with arthrogryposis, and then that one on the right is a baby with clubfoot associated with spina meningomyelocele and spina bifida. So syndromic clubfoot is clubfoot in a patient with other syndromes. So there are many syndromes that are associated with clubfoot, like the Beckwith-Wiedemann, the trisomy 18, among many other syndromes. In terms of etiology, the real cause of clubfoot is not known. As you shall see evidenced by the abundance of many theories that have been proposed. So from the very beginning, Hippocrates proposed a mechanical theory postulating that clubfoot would result from a raised intrauterine pressure, but it has been disputed because of absence of increased incidence in multiple gestations, large babies, and polyhydramnios, or which would be normally associated with the increased intrauterine pressure. Then the other theories include the neuromuscular theory, where it has been proposed that there's an increase in the type 1 S/2 muscle fiber ratio from 1:2 to 7:1. But however, Iran did not observe such abnormality. The histological theories is discussed by various authors. Lorraine found an abnormal peroneus brevis histology, and Iran found a primary germplasm defect, and Shapiro and Lemaitre defects in cartilage. Ionescu increased collagen synthesis, and then Ippolito and Ponseti came up with the theory of restriction fibrosis of the distal muscles of the calf and supporting connective tissue. Again, anatomical theories, Ippolito found out that there was medial angulation of the talar neck and medial tilting and rotation of the board of the talus. Hutnik et al. Found that there is hypoplasia of the anterior tibial artery, and Teko and Porter found an anomalous muscles in 15% of the patients with clubfoot. The theory of arrested fetal development, it was first described by von Volkmann in 1863, and the foot found out that it's actually sorry. All right, sorry for that. Von Volkmann found out actually that congenital clubfoot is a disorder or a deformation of normal development of the foot. So in utero, the foot is normally in equine varus, and this usually corrects to a pronated foot at birth. Arrest due to an intrinsic error or environmental insult results in a failure of correction of the physiological position to a normal pronated foot. So that's the theory of arrested fetal development. Then the consensus theory incorporates all the theories, and it is the one that probably best explains the occurrence of clubfoot. We'll move on now to factors that point towards a genetic factor. So genetic factors have been implicated, but there's been no clear mode of inheritance. But factors that point out to a genetic factor in congenital Talipes equinovarus include the fact that 25% of the cases have positive family history, and in about 2.5 to 6.5%, there's a chance, there's a 2.5 to 6.5 chance of a patient being born with clubfoot if the sibling has clubfoot. And there's a 33% concordance in monozygotic twins, which decreases to 3% if it is in dizygotic twins. And there's been a recent link to that transcription factor PITX1, which all point towards a genetic cause etiology to clubfoot. Then for environmental factors, these have been found to be linked to congenital or clubfoot. The maternal smoking increases the chance of clubfoot by about 1.3 times. And then early amniocentesis, that is in the period 11 to 13 weeks of gestation, has also been associated with clubfoot. And low birth weight, maternal alcohol consumption have all been linked to clubfoot. In terms of the pathophysiology and pathoanatomy, like I mentioned earlier, it is a developmental deformation, and it has been noted that there are thickened ligaments and tendons and capsule due to excessive synthesis of collagen. And then the collagen fibers, in terms of arrangement, they've been found to be wave as depicted by the pictures there, the photomicrograph and the slide. And they are small and short leg muscles as well. The arrangement of the fibers into a wavy pattern, also known as crimp, is also used in terms of treatment, because it means the ligaments are easily deformable, and they can also they can unpack, so to speak. In terms of pathoanatomy, the tarsal bones are in external in extreme flexion, adduction, and inversion. Then the talus is severely plantar flexed, and the talar neck is medially and plantarly deflected, as depicted in that photograph. The navicula is severely medially displaced, and the calcaneus is adducted and inverted under the talus. In terms of making a diagnosis, it is chiefly a clinical diagnosis, and when you encounter a patient with clubfoot, you need to take a thorough history, including prenatal and family history, and then do a thorough physical examination from head to toe, not just concentrating on the foot. The role of prenatal ultrasound is depicted in the slide there. So during the first trimester, you can actually pick up associated anomalies, because some of the clubfoot is associated with other syndromes. And then the second trimester, that's when you can pick up the true club fit. Then in the third trimester, there's a high false positive rate because of intrauterine crowding. Then that ultrasound is just to show a club foot in utero, as depicted by the arrow there. Then radiographs are rarely taken, but if they are taken, the recommended views are the Teco view, which is a dorsiflexion lateral view, which shows a hind foot parallelism. As you can see, the talus and the calcaneus are almost parallel to each other. And the talocalcaneal angle, that's the angle that is created by lines that are bisecting the long axis of the talus and that of the calcaneus is less than 25. Normally, it should be between 35 and 50. And then there's also a flat talar head. Then the anterior-posterior view, you also see a hind foot parallelism, and then the kite angle, which is the angle between the long axis of the talus and that of the calcaneus, is less than 20 degrees. It is normally 25 to 40, sorry. And then if it's less than 20, then you can diagnose club foot. The negative talus first metatarsal angle. As you can see in a normal foot, the angle between the long axis of the first metatarsal and that of the talus is in the positive. But when it is in a club foot, it falls into the negative as depicted by that arrow. In terms of classification or grading, we commonly use the Pirani for monitoring treatment and early progress, and the other classification or grading systems are also mentioned for completeness, but we will discuss probably the Pirani. So the Pirani scoring basically measures 6 parameters which are graded from 0 to 1, from 0 being normal, 0.5 being a mild abnormality, and 1 being a severe abnormality. There is a midfoot contracture score, which measures the curved lateral border and the medial crease, as well as the lateral head of the talus. And then there's a hindfoot contracture score, which measures the posterior crease, the rigid equinus, and an empty heel. So for the lateral border, you can place a straight, you can draw a straight line of, on the curved lateral border. So if the line, or if and it is abutting the fifth metatarsal or 50 toe, it's a normal foot. And then if the curve starts just midway along the lateral border, then it's a mild 0.5. And if it is starting quite proximally at the calcaneal cuboidal joint, then it's a 1. Then the medial crease. So if there are multiple fine creases that do not alter the shape of the foot, then it's a 0. But if there are 1 or 2 deep creases which do not cause significant, that's a mild, and that's a 0.5. But if there are deep creases with a cavus, as noted there in 1, then it becomes a 1. Then the lateral head of the talus, if you can palpate completely the head of the talus, then that's a 1. That's the severest form. But if you can palpate it partially, it's a 0.5. If it's not palpable, that's very normal. That's a 0. And the posterior fold, again, like the medial crease, if it's multiple fine creases, 0. one or two deep creases with no which do not actually you can visibly see a deformity on the posterior aspect. Then it's a 0.5. If you can see a deformity, that's a 1. Then palpation of calcaneus in the heel, you cannot palpate it at all. It's a 1. That's the severest form. And if you can palpate it, the consensus probably is that like that of the nose, and it's a 0.5. And if you can easily palpate it, like you can palpate on your forehead, then it's a 0. And in terms of the equinus, the last one, if you can flex it in neutral, that's a 0.5. That's the mildest. If it cannot be flexed at all, that's the severest. That's the equinus. And if there's some degree of section, it's a 0. That's normal. That's all about the Pirani scoring. Move on now to treatment, and our guest is going to take us through. As a way of a summary, and operative treatment. And non-operative is the basis of treatment for most of the clubfoot. And of the non-operative method, the Ponseti method is the gold standard in most of the world, and it results in greater than 90% success rate in avoiding extensive surgical release. But for completeness sake, the other methods are mentioned: the French method and the kite method. I will hand over to the next presenter.
Okay, thank you very much, Dr. Matenga. I hand over to Dr. Larry Rajos.
Hello, good morning. Thank you everyone for your attention. And I think the previous speaker has done a wonderful job of explaining the basics of clubfoot to all of you. Can you see my screen?
Yes.
All right, great. So I'm sorry about my video. I don't know what the reason behind that is. But I think you can see my slides, so I'll go right ahead with the treatment of clubfoot. And I won't focus much on the etiology or the scoring system because the previous speaker has already done that. But what I will do is to give you a brief overview of where do we stand with clubfoot treatment in the year 2020. So to briefly give you an overview, clubfoot is not a new condition. As you can see, King Tutankhamun from Egypt in the 13th century before Christ was diagnosed with a clubfoot. And you can see from this computer modeling, which was made digitally from his mummy, you can see that he has a visible clubfoot and also a scoliosis. If you look at this picture in the Louvre Museum, you can see that there's a painting by Jose de Ribera, which shows a clubfoot in a farmer boy. And it's debatable whether this is a true clubfoot or whether it's arthrogrypotic, because you can also see that his upper limb has evidence of contractures as well, in addition to the clubfoot. So if you look at the treatment of clubfoot over the centuries, you will realize that there's this pendulum where the arc moves from conservative to surgical treatment and back to conservative treatment. That's interesting because that's true for various aspects of orthopedics, not just clubfoot. If you look at the 4th century BC, Hippocrates, who's the father of medicine, in fact recommended treating clubfoot by conservative methods. And he said that you should manipulate the foot gently and then tie the foot up with resin bandages so as to correct the clubfoot. Surprisingly, if you're born in the 18th century, the treatment of clubfoot is actually surgical. And in fact, you'll see that Delpech and Strohmeyer from Germany were strong proponents of the surgical treatment of clubfoot. In fact, Little, after whom Little's disease has been named, had a clubfoot which was treated by Strohmeyer with a tendo Achilles tenotomy. If you go back again then to the early 19th century, when plaster of Paris became commonly used for different fractures, Guérin, in fact, described the use of plaster of Paris to correct a clubfoot. But then again, you can see in the latter part of the 19th century and the early 20th century, surgeries became popular once again. And you had advocates like Phelps, Brockman, and Steindler, who described various posterior and medial releases and even bony surgeries at times to correct the clubfoot. Around the 1930s, again, conservative treatment became the norm, and Hiram Kite from the Texas Scottish Rite Hospital became one of the most leading advocates for. But again, towards the 1970s, the pendulum swung towards the posterior medial release, which was described by Turco and Simons. And finally, you can see that around the 1950s, and then again becoming popular since the last 20 or 30 years or so, the Ponseti method, which method has seen a resurgence of interest. So this is an interesting thing that I found from the history of literature, that though we consider conservative treatment to be something new, it's been there with us for centuries. And though we consider sometimes surgeries to be a 21st or 20th century phenomenon, actually it was described way earlier than what we assumed. So historically, if you look at the various treatment options available in literature, you can see that that's from Hippocrates, who described understanding the fact that the foot should be molded gently, almost like wax. Around the 19th century, clubfoot braces became popular, and the Thomas's wrench was actually used to forcibly correct the clubfoot into the corrected position. So it just shows that over the span of the centuries, how the treatment has evolved from being gentle to being forcible, and then again to understand once again that we have understood the concept of being really gentle when treating clubfoot. So here we see, I found this pictures from Kite's textbook, and this was his method of manipulation. As you can see here, the beautiful molding that the cast has over the foot. And these are something that we need to emulate as orthopedic surgeons. I feel plastering has become a forgotten art. We have relinquished that role to plaster technicians and physiotherapists and other people. But I think the true skill of a surgeon is being able to apply a cast in a really well molded fashion. And sometimes applying a good cast is more difficult than some surgeries that we do. And I think what we have learned from Kite over the last many years is this famous aphorism, which is attributed to him: what is gained without force is achieved without harm. And that's absolutely true, not only for clubfoot, but for so many things in orthopedics, where brute force is not required, but gentleness for the soft tissue and the bones are crucial for us to get a good result. As I've shown you, around the 1970s, starting with Turco and then moving to surgery, various tissue procedures became the norm. And I will show you some of this in later slides, but you can see this is the typical posterior medial release that was described by Turco using a medial incision. Here you can see the exposure of the talonavicular joint. Here you can see the exposure of the subtalar and the ankle joints. Once again, showing you the talonavicular joint exposure, where you have the head of the talus exposed inside the foot, and a subtalar exposure going circumferentially from medial to the lateral side. You can achieve this by various incisions. Some of them are the posterior medial incision, or you could use the Cincinnati transverse incision popularized by Crawford in 1980s. Around the same time, in another part of the world, in France, the French method became popular. And this was described by Bensahel and Demeglio. And I actually visited the center about 15 years ago. And I saw how they understood the gentleness that was required to manipulate a clubfoot. Each patient, they would spend almost half an hour or so gently manipulating the foot by various different maneuvers. And this is a video that I shot at the time of my visit there. And as you can see, again, gentleness and patience was the key to achieving a clubfoot correction. But what's become popular over the last 20 years or so, where there's been a resurgence of interest, is the Ponseti method. And this is a method which has now been endorsed not only by the WHO, but by various organizations around the world. And if you understand what the Ponseti method is, it has 4 important steps. It has a specific method of manipulation to stretch the contracted ligaments. There's a specific method of treatment. And as you can see, these are Ponseti's publications, which have been over the years been described. But what has become popular are the internet support groups. And Ponseti himself said that it was because of the parents who formed these internet groups to popularize his method. His publications, as you can see, are extremely popular. And then in 1996, he published a book, which I feel all of you all should read. It's available as a free download from the Ponseti International Association website. And it's a fascinating account of how he devised this method and his understanding of what clubfoot actually is. So these are the important publications, and I would suggest anyone who's interested in clubfoot should read these publications because they give a beautiful understanding to this man's approach. So if we look at what the goals of clubfoot treatment are, whether it is by surgery or by conservative methods, are to achieve a functional, pain-free, normal-looking plantigrade foot with good mobility, without calluses, and requiring no modified shoes. If you try to understand the reasons why the Ponseti method worked, in fact, we need to go back before Ponseti. And Ponseti himself has attributed his understanding of the foot to two important people. Farabeuf from France, who described the movement of the calcaneus like a boat in the ocean. The way the boat rolls, yaws, and pitches, that is the way the calcaneal moves as the foot goes from adduction into abduction. And then again, from Usen, who described the axis of the tarsal joint, not just like a mitered hinge, but rotating around a moving axis. And he defined this as a closed kinematic chain, which he called as Dikinetischkeit. And this is what we call as kinematic coupling of the subtalar joint. So if you understand the functional anatomy of the subtalar joint, this is the key to understanding the Ponseti method. And as you can see here, as a subtalar joint, the axis is 45 degrees from above to below and 20 degrees from medial to lateral. And what Farabeuf and Usen showed from their thesis is that as you abduct the foot without touching the calcaneum, because of the kinematic coupling of the subtalar joint, the calcaneum will abduct, resulting in correction of heel varus and the equinus. So this is the key to understanding the Ponseti technique. It's not based on Ponseti's own work, but he acknowledged the fact that previous biomechanists had understood the anatomy of the foot and the fact that because of the kinematic coupling of the subtalar joint, by abducting the forefoot, the hind foot would also correct. So the 3 important steps in the Ponseti casting are to go exactly the way the deformity has been described in the cave fashion. To correct caves first by elevating the forefoot and to align it with the hind foot. To then abduct the entire foot under the talus, keeping the foot in slight supination. As one does abduction of the forefoot, because the kinematic coupling of the subtalar joint, the heel varus corrects automatically without the need to touch the heel. And finally, the last step in the correction is the correction of ankle equinus by doing a percutaneous tenotomy of the tendo Achilles. So here, as you can see, is a little baby with a bilateral clubfoot, which is extremely severe. And with the help of 4 to 5 plasters, you can see that the entire foot is well corrected. So it's important to understand how well the foot is molded, similar to the picture that I showed you from Kite's textbook, that the key here is to form a really well molded plaster, which is well fitting, which will actually correct the deformity within a span of 5 or 6 casts, followed by a tendo Achilles tenotomy. So how does one learn the Ponseti technique? I think over the last 10 or 15 years, this phenomenon has really spread all over the world. And in fact, in Africa, has been the leaders in showing that the Ponseti method can be developed in the form of a program by teaching medical officers, orthopedic surgeon, physiotherapist, the essence of the Ponseti method by the form of various training workshops. And we have now associated ourselves with various non-governmental associations and non-profits like Cure, Miracle Feet, and various other organizations, which help us to train various medical specialists. And the key here is to form a standardized curriculum of lectures, a hands-on workshop using foot models and real cases of babies with clubfoot, have a standardized set of teaching presentations, small number of participants so as to have a high faculty to student ratio, and active mentoring by faculty. And I know that many of you all have attended clubfoot training courses in various parts of various countries of Africa. And thanks to the efforts of the Global Clubfoot Initiative, which is based in Oxford and London, we have also developed an Africa curriculum for training of medical personnel in the Ponseti method. We have also developed certain apps which will soon become available to most of you. Those of you who are interested can later on write to me. Once these are developed well, this will be a form of mobile applications as an e-learning tool to supplement our in-person training, which has various modules of anatomy, the pathophysiology, the reason why the Ponseti method works, the technique of various steps of casting, manipulation, and tenotomy. We have also developed a 3D model of clubfoot by working with a Spanish company which specializes in making medical 3D models. And this will be a fascinating way to learn not only the Ponseti method, but how clubfoot, the anatomy of clubfoot, the various structures, how they are aligned, and to understand the Ponseti method of manipulation in various anatomical planes. And this is a work in progress. I assume within the next year or so, we'll be rolling this out in various programs in Africa. I will now wind up by talking a little bit about the older child, because we know that the Ponseti method is the standard of care for the younger child. But coming from countries in Africa and Asia, I know that we have similar characteristics. And we have a large number of children who come to us in the walking age, that's usually after the age of 1, 2, or even older, who have never had a clubfoot treatment before, or if they've had treatment, the foot has relapsed once again. And this is a real challenge for us who work in low-income countries. And how do we treat this? We must understand that in the walking age, things are a little different, because walking imposes unique challenges on a deformed foot. There are increasing soft tissue contractures, the deformation of the tarsal bones. These feet are generally stiffer. They have callosity, skin fissures, and bursae. And I would like to draw your attention to this wonderful monogram written by Dr. Norgrove Penny in 2005, where he described the various modalities of treatment of the neglected clubfoot. So in short, through this algorithm, you can see that for many years, we used to believe that the treatment of an older child, and we used to follow an algorithm which included starting with a soft tissue release. If we found that there were persistent deformities, we would resort to certain types of bony surgeries, mainly on the lateral aspect. And depending upon which deformity persisted or recurred, we would treat it by a variety of different soft tissue and bony surgeries, going from mild forms of surgeries to fairly severe and major surgeries like a triple arthrodesis or even a telectomy. So if you look at the various soft tissue procedures, you'll realize that you have a variety of soft tissue procedures described. You can either have a posterior release, where one releases only the posterior structures, which includes the tendoachilles, the ankle, and the subtalar capsulotomies, or what can be much more extensive by doing a posterior medial or even a posterior medial lateral release using either a Cincinnati approach or the Turco posterior medial approach. And I think the incision is not important, whether you go medially, posterior medially, or circumferentially. The important aspect is to release all the important structures medially, posterior laterally, and posteriorly. And I've already shown you the various steps of these soft tissue procedures. And I know that 20 years ago, when I was a younger resident, like most of you are, surgeries was the treatment of choice for club feet. We would start casting the children when they came to us. And by the age of 6 or 8 months, we found that many of them would not respond to surgery, would not respond to plasters. and therefore go ahead these soft tissue releases between 8 to 12 months of age. And with the Ponseti method becoming popular over the last 20 years or so, almost all of these children have now been treated by conservative methods. So here's an example of a 6-year-old child who came to us walking on these severely deformed feet. And as you can see, at 2 years follow-up and at 14 years follow-up, if you've done the surgeries well, respecting the soft tissues, not causing cartilage damage, soft tissue surgeries can give you a good result. However, they require a large amount of expertise. Do not take these surgeries lightly. And it's always been said that a poorly performed conservative treatment still has better results than a poorly performed surgery. So take these surgeries really seriously. They require a high level of skill, but if it's done well, with good respect of soft tissue and the soft cartilage, you can get a good result, despite the bad rap that surgery has been having in recent publications. But of course, you also see children who come to us much older, and I'm sure that each and every one of you who has worked in your community hospitals will see children who come to us even later. And your example, for example, is an 18-year-old boy with bilateral untreated club feet. And unfortunately, at this age, sometimes even soft tissue surgeries won't help, and you have to go ahead with more disabling surgeries, such as the triple arthrodesis done in the form of the modified Lambert-Eaton procedure. And here's the result on a short-term follow-up. Remember that, again, these feet are plantigrade, but not necessarily pain-free. And it's important to note how these feet will do in the long term, because these are quite radical and disabling surgeries. They give you a good short-term cosmetic and functional correction, but in the long term, they can become painful and have a lot of recurrences. This is another method described as a one-stage procedure by one of my colleagues from India, where you do a wedge tarsectomy, because he frequently had patients coming to him from tribal areas where patients wanted a one-step go back to their villages as soon as possible. And he developed this wedge tarsectomy, where you removed a large wedge of bone dorsolaterally, excise the extra skin, and then pin it with K-wires and do a one. Good in the short term. I'm a little skeptical of what will happen in the long term when you have joints which have been violated and therefore fused. In India, of course, and I'm sure in some countries in Africa, you're using mini external fixators. This was also popular many years with us. And I'm trying to show you that for treating these walking age children, there should be various tools in our armamentarium. As an orthopedic surgeon, we must have skills to treat the clubfoot with various different modalities and finally choose the one that we're most comfortable with. So I'm showing you a range of different modalities that have been used. This is a mini external fixator being devised in India, which is called the JES fixator, devised by a surgeon, a hand surgeon called Dr. B.B. Joshi. And as you can see, if it's done well, again, by doing soft tissue distraction. So this is basically, again, the Ponseti method, utilizing an external fixator, which is low profile, which has pins rather than shank screws, and gives you a fairly good result if done well. And then, of course, for the Ilizarov enthusiasts, we know that in the older child, the Ilizarov fixator also works extremely well. There have been various reports over the last several decades, not only from Russia, but also from Europe, especially Italy, where it became popular, from the US by Rod Paley, who have shown that in these very old severe deformities, the Ilizarov fixator can also give a good result. But you have to understand that each of these surgeries require a high degree of skill and expertise. So the question is, with this role of the Ponseti method in the younger child, could we use this method in the older child as well? I've shown you the various tools that we have in our armamentarium, and you can pick and choose the one you like best. But we were intrigued by the Ponseti method, which we adopted more than 20 years ago. And the question that was always topmost in our minds, that since we have used the Ponseti method in the younger child, will it have a role to play in the older child as well? And since the last 15 years, we have expanded the use of the Ponseti method to older children as well, starting with children up to 1 year, and then gradually increasing our age limit till the oldest child that we have treated with the Ponseti method is 10 years of age. And for those of you interested, we published our results in 56 children in the Journal of Pediatric Orthopedics last year. And of course, there are several unanswered questions when it comes to the older child. How many casts are required? Should you do a tenotomy rather than doing an open Z lengthening? How do you brace these walking age children? Because obviously they're not going to use the braces for 23 hours in the day like the younger child. And what's the risk of relapse? So to answer some of these questions, we did our study. And I will show you here, this is a very busy slide, but I'll focus on just a few things. That we had children from 1 to 10 years of age, with a median age being around 3 years. And we found that we had two groups. Group 1 are the ones who had never had any treatment before, but group 2 were children who had treatment in other centers and who then relapsed. And in both of them, between 5 to 7 plasters, we could get a correction. Though, of course, you can see there are some outliers. There are some patients who required 17 plasters, some who required about 12 plasters. But the good news is that we got primary correction in all of these patients, and that's surprising. 100% of the children in the untreated group needed a tenotomy, whereas about 70% needed it in the relapse group because some of these children already had previous tenotomies. But the relapse rate is pretty high, ranging from 30 to 45%. So these are children in whom you can get a correction with the Ponseti method, but the chance of relapse is quite high in them. And here are a few cases for those who don't believe that the Ponseti method actually works. Here's a 6-year-old girl with a completely untreated clubfoot. You can see how severe that deformity is. 15 years ago, I would say this needs soft tissue surgery, maybe bony correction, might need a fixator. But here are both of these children at a short-term follow-up of around 3 years of age, treated only with the Ponseti method and a tendo-Achilles tenotomy. And I have now become a very strong proponent of the Ponseti method, even in older children, because I feel there's no harm in trying this method, even for rigid and severe deformities. To give you an even bigger perspective, here's a 26-year-old lady whose daughter had clubfoot treated by us. And then the father brought the wife from the village saying that my wife also has clubfoot. And since my daughter has been, feet have been so well corrected, can you do the same for my wife as well? And here I will show you that with 19 plasters done serially, followed by limited surgery. So our method has worked entirely in this lady at this older age, but combining conservative treatment with very limited soft tissue radical surgery. All that we have done is a plantar fascia release, a tendo-Achilles tenotomy, and then because she had a residual curved border, we did a lateral column shortening through the cuboid. And by casting combined with very limited surgery, free plantigrade foot, which you can. And this is not just our results from India, but you can see from various other countries around shown. So to wind up, I would say that the take-home messages about treatment is that the Ponseti method is the standard of care for clubfoot. Of course, soft tissue surgeries, fixators, osteotomies, arthrodesis were all traditional options. And they occasionally do have a place even in 2020 for treating resistant and recalcitrant deformities. But I would suggest to you that the Ponseti method combined with judicious, limited soft tissue or bony surgery is an attractive option today, even for the older child. Of course, we must be aware that the risk of relapse is high and regular follow-up is the key. Thank you so much for your attention.
Thank you very much, Dr. Larry Karagius, for the presentation, and Dr. Kudakwashe Matenga. I'll open the floor to any questions, but I think I have two comments because there had been some questions that were posted whilst the presentation was going. First question was, how long is casting done for, or if I understood the question properly? So you, with Ponseti technique, there are two different variants of casting. Changed, a weekly change of casts, and there is what we call the axial Ponseti. This is done cast change it 3 to 4 days, depending on how severe the club foot is. So there are two variants
to it, but the classic Ponseti one is a weekly changed casts, but of late, you know, people do research and follow up on results of casting techniques, and the accelerated method has also been accepted as a way of casting. And the other question was on high arc foot. The person who asked this question just said, can you comment about high arc foot? So when we are talking of an arched foot, usually we call that cavus foot. Cavus foot is in relation with usually neurologic problems, you know, like Charcot-Marie tooth, spina bifida, things to do with post-polio, cerebral palsy, like this. This is not specifically a club foot, a cavus foot, which stands on its own as a diagnosis of cavus foot. So with cavus foot treatment, it also depends on how rigid it is and flexibility and what the problem is exactly, because it leads to poor distribution of pressure on the ball of the foot and on the heel when a person is walking, which then leads to pain. So you would have to read more on cavus foot as a different diagnosis, not associated with club foot. So I'll open the floor to questions, but I had questions of my own. First question was, you are, let's say, an orthopedician, pediatricians, to see if a child who, let's say by SVD, has club foot or not. So how do you actually do a clinical assessment for you to say, yes, here we have club foot, or no, we don't have club foot? Because I think in the presentation by Dr. Kudakwashe Matsenga, he talked of clinical club foot being a clinical diagnosis. So what clinical things are we actually looking at for us to say, yes, here we have club foot and here we don't? Any trainee to answer this question? Yes, Dr. Ngoy. Can you unmute? We can't hear you. How do I unmute him? Dr. Ngoy, we can't hear you. Unmute. Okay.
Yeah, I was saying that we consider the deformity of the patient. Of course, we have to take the general assessment of the patient to see if it's syndromic or not. And then when after assessing the general condition of the patient, then we go to the local. The local, we take the deformity as prescribed, as described by Dr. Matsenga, the clavus, the adductors, the varus, and the iguanus. Then, if we have those deformity, if those deformity, they have to be the second step. The third step is to see if these deformities are correctable in hand or not. If they are correctable in hand, then I wouldn't take that deformity as a club foot. It might be postural, it might be something else. But if it can't be corrected in hand, then we will take it for a club foot.
Okay, what simple test can you do for you to check general flexibility, especially when you are dorsiflecting the foot?
Yeah, you have. We'll try to correct you do the lateral pressure on the head of the talus, lateral pressure on the head of the talus, and trying to put it in the abduction, the forefoot, the maneuver.
Okay. So I hear we are running short of time, but you bring the foot to the shin bone for you to see if the foot touches the shin. So I hear we might have to conclude. Are there any one last burning question from the floor before we close? Because we are out of time. Okay, if there are no burning questions, I would like to thank Dr. Larry Aragis for your presentation on treatment. It covered well a lot of things, and as well Dr. Kudakwashe Matenga for your presentation, which I think covered the majority of things at least to give an idea for trainees to read more on the topic. So thank you very much for today. Thank you to everybody who has attended, to our faculty who attended as well. Dr. Matenga, I hand over to you. Chisamatanga, sorry.
Yeah, thank you so much. I'd like also to thank our other colleagues. I saw Professor Kambarami was amongst us, Mr. Dr. Tickley, and all the other colleagues that joined us. We'll be informing you of other pediatric ortho presentations as the year progresses. Thank you.
Thank you so much for inviting me. Bye.
Bye, thank you.